everything makes it into the headlines, but we bring you the full story. Join Ujunwa Cyril Anyoke, a renowned media personality and former president of the Nigerian Publishers Association, as he unpacks the real issues behind the news, from politics to public policy, economy to human rights. Nothing is off limits. Expert guest, in-depth conversation, local and global perspective. New episode every week on Facebook and YouTube. Watch now on Freedom Square TV. Follow for updates and behind the scenes clips. Beyond the headlines, beyond the news.
Hello, good morning, and welcome to another insightful edition of Beyond Headlines of Freedom Square TV. And as usual, we are reaching you from our Enugu studios. Every year, thousands of families receive news that shatters their world. Their child has a heart defect. While medical science has made leaps and bounds, a painful question remains: are the systems, the funding, and the policies keeping up to save these young lives? Today, we're asking the hard question: are we doing enough? Many people associate heart diseases with adults, but thousands of children around the world are born with or develop heart conditions that can affect their growth, education, quality of life, and even survival. So today, we turn our attention to a health issue that often receives less attention than it deserves: heart disease in children. Do you know some children are born with defects in the structure of their hearts? Others develop heart problems due to infections, rheumatic fever, genetic disorder, or other medical cause conditions. And of course, like I said before, the question before today: are we doing enough? To help us actually understand this critical issue, I'm being joined actually in the studio by a consultant pediatrician and a professor of pediatrics at the University of Nigerian Teaching Hospital in Ujunwa. And he's also the publicity secretary of Nigerian Society of Pediatrics Cardiologists and a fellow of Nigeria Cardiac Society. He's no other person than Professor Fortune Ujunwa. Oh,
thank you, sir. Thank you.
Good morning.
Good morning, everybody. Thank you very much, sir.
Okay. Let's understand what heart disease in children means, because I said earlier, many people hear the phrase heart disease, they're associated with adults. So can children really suffer from heart disease? And if they can, what are these heart diseases?
Thank you, Doc. It's interesting that, yes, most times we associate heart disease to adults. However, the heart diseases in children are also very common. The heart diseases in children are of two types. You have what we call the congenital heart diseases. These children are born with these heart diseases. They give birth to them like that. So they have, in the normal parlance, we call them hole in the heart. Also, they also have other heart diseases in children, like we also have in adults. Things like the commonest is acquired heart diseases. You have things like rheumatic heart disease, dilated cardiomyopathy, then pericarditis, and other arrhythmias. Maybe the heart is beating irregularly. And also shock us. We also have what we call pediatric hypertension.
What is that?
Hypertension in children.
Children as old as?
From birth.
Kind of hypertension people like us are going through.
Yes.
It's quite amazing.
Thank you.
Okay, these heart diseases, are they genetic?
Well, there are genetic components and there's also environmental components. Like most of the congenital heart diseases, the ones they are born with, the one we call hole in the heart, some of them are genetically engineered. Then These are maybe the mother, the siblings, or the relations have this heart disease, and they have what you call sibling risk ratio. They also can develop heart diseases in their siblings, and some also have some risk factors that can predispose them to these heart diseases, especially in the mother. If those mothers have things like diabetes in pregnancy, they have taken some drugs, exposed to certain drugs, certain illnesses while they are pregnant, they can also, when they give birth to these children, they have heart diseases, congenital heart diseases mainly. Then the acquired heart disease, like rheumatic heart disease, is mostly due to environment with certain genetic components, because we live in a resource poor environment, socioeconomic status are poor, we live in a poor housing environment. So these children can also develop what we call rheumatic heart disease, following simple things like sore throat. So it's a sequelae of sore throat. All the sore throat that we have. So a sequelae of sore throat is rheumatic heart disease.
Okay, how dangerous are these conditions?
An understatement, just be modest about it, is one of the major contributors of childhood mortalities in the world. Globally, more than 309 over 300,000 children die annually due to heart diseases, and interestingly, 90% of these deaths occur in low and middle income countries. The Western countries, the high source income countries, it has actually been decreased so much, but we are still in resource poor environment, so they are very dangerous if not taken care of. They cause death.
But can any child outgrow some of these health conditions? Health treatment.
It's interesting. I say that these children, they are born with this. In certain cases, some of them don't live up to a week. There are some heart diseases in children that they can't even live up to a week. Things like hypoplastic left heart syndrome, then transposition of the great arteries. These children, if nothing is done within 1 week, he's dead. Then some can progress over time. If the surgery is not done, then they cannot have surgery, and before you know it, they are dead. So most of them, when they don't have access to health care, surgical intervention, treatments, both interventional and open heart surgeries, they die.
Well, you talked about advanced countries and you talked about, of course, our developing countries. One big challenge that most parents not easily recognize these symptoms early. So, what signs should raise concern?
That's why we chose the topic, are we doing enough?
Yes.
We are not doing enough. We are not even aware. Like you just said, that the children have heart diseases is a big challenge, because we are not doing enough. I want to thank you especially for even giving us this opportunity to be in this forum to talk about it. This is an opportunity we rarely get in certain quarters. However, the signs are simple. Once a child is born, if the child doesn't cry at birth, if the child is blue, maybe the tongues are blue, it's not breathing fast, if the child is not gaining weight as you expect, or child is suckling and doesn't stay a very long period on the breast, it is a sign. Even we health workers, before we discharge any child from the hospital, we must check. There's a simple instrument we call pulse oximeter. You check the pulse oximeter and check the oxygen saturation of this child. By just doing that, you can detect it early. However, in this environment, more often than not, these people come when they are so bad that you can't even do anything. They'll come when they already have heart failure. Because what we are saying is that we want to prevent them from having heart failure, from dying from these heart diseases. So when they come, they have to just come and we check them, go to hospital. That is the problem. The signs are there. I'm not trying to talk about the highfalutin signs, but it's the basic signs the mother should notice at home. From birth, if your child's tongue is blue, if your child's fingers are turning blue, doing as if they are coughing, if your child is breathing as the child is breathing, the chest is going inside, you see an obvious bulge. Then if you even look at your child, you see the child doesn't look like other children, or looks like something we call Down syndrome, or have some congenital abnormalities, that is something that is not normal, just take that child to the hospital, and then you can now look for it. Most of these heart diseases are discovered incidentally, even when you come for other checkups. Then when you look at these children, you now detect that this child maybe have what we call an abnormal sound in the chest, in the chest, which is not sounding very well. Then you can now go further and do the highfalutin test. But we're just saying the simple things we do. Poor weight gain. The child is not growing. It's not a child that is 6 months. It's supposed to be outgrowing clothes as at when due. But the child is wearing one clothes from birth. Then the child will now go and say that the child has intact. Please, once you say that the child has intact, please check the heart.
Which one is intact?
That's the point.
Which one is intact?
You see, there are this in the local parlance, what these mothers call intact. The entire that the child is not growing well, that is entire is all this meat. So it's very common. Then the next thing, the child's heart is beating very fast. That is beating, and you see obvious cardiac pulsation. They will go and put scarification. Please, once you see those things, these are the signs. Please take the child to the hospital for proper evaluation.
Okay, we're not doing enough. We're not a nurse. But when a young lady, maybe 2021, is pregnant, you go for antenatal. Is there anywhere these conditions you mentioned, are exposed to the young mothers? I don't know what happens there. I've never been there, because that's part of we're not doing enough. So, what kind of during antenatal? What kind of communication should they have? What kind of information should be available to a young mother? Because when we say when they notice what? It's not been a mother before.
Hey, you are very intelligent. I must give it to you. You are quite intelligent. I know. You see, it's not easy to organize this kind of thing. You are quite smart. You see, these are why we are saying we are not doing enough. Prevention is the key. When we're even very small, they say prevention is pre-conceptual care. That is, before the even mother know that he's pregnant, before the mother knows that he's pregnant, the heart has formed. Are you understand? That is, before you miss your first period, the heart has formed. And most times when these mothers are pregnant, they don't even know. They take all those drugs that can even cause problem. And they can take that problem that can cause problem. So you start, before they get pregnant, you start telling them to plan their pregnancy. That's why my students will say pregnancy was planned and conceived. You see, when you plan your pregnancy, you be careful. So even the drugs we take, the first week they tell you have malaria, all those you will go and take all sorts of drugs. Take all sorts, even the one that make the child to get small. You take all sorts of drugs. You are not taking folic acid. You are taking some other drugs, and where you get that can affect the heart. Even if there are people that have some conditions, like they are taking things like warfarin or some anti-clotting agents, those ones can predispose them to heart conditions. Then, when they are pregnant and come for antenatal, the onus now lies on the doctor to be checking them. They have what we call fetal echocardiography, pre-antenatal care. They will be monitoring the growth of the baby. They will be advising them on nutrition. Because the heart disease is not just the congenital one. The problem is even the acquired one and the one that will come in future. Because when a mother gives birth to a low birth weight child, the child that the weight is less than 2.5 or 2, that child runs the risk of developing hypertension and diabetes in future. So antenatal is the key. Everybody is a stakeholder. From antenatal, they will control the sugar. If the sugar is high, A mother that has high sugar is bound to develop the risk of giving birth to a child with hole in the heart, the terrible one, transposition of the great arteries, is so much. If a mother has rash during pregnancy, the tendency to develop a child with congenital rubella syndrome is high. So that immunization of mothers, childbearing mothers for rubella is very key. We've started mass immunization for rubella in Nigeria. This is very good. So these mothers will not have rubella during their pregnancy. This rubella will predispose you to hearing deafness, cataract, blindness, and even heart disease. So most times, most of these heart diseases, they don't come just single. They come with their brothers and sisters.
That's quite interesting. Okay, you said they should undergo some kind of screening, and my concern would be how accessible are these services, and do we have enough specialists, people like you, now that our doctors are doing JAPA?
In the US, you have about one pediatric cardiologist to about 120,000 people. In Asia, you have one to 16 million. In low middle income countries,
In Nigeria,
we have 1 to 33 million.
1
To 33 million.
pediatric
Cardiologists to 33 million.
that is somebody like you.
Yes, to have as that is the ratio. That is the recent World Heart Federation population. So this is the ratio is so. You see, in our association we've been clamoring. Let people come. Let them be trained, and let the government make the condition, because part of the challenges we have is workforce, pediatrics workforce. The policy statements make the system conducive, train people, and it's not just training people, retaining people in the system. So we in Pediatrics Association of Nigeria and in SOPAC, we advocate for these children. We also advocate, we organize training, we have seminars, even there's one coming on 20th June. So we keep updating ourselves, we keep encouraging the young ones into the residency fellowship, because the government should sponsor these young ones, make it attractive, fund their training, and retain them, and make the policy, remunerate them, incentivize the whole place so that they have good incentives. However, interesting part of it is this: most of these trained cardiologists or trained doctors are located in urban population, and the problems are in the what? Hinterlands. So it's a complex problem that all of us must face. Stakeholders must come together and chart a course. We are in Enugu now. How many pediatric cardiologists do we have in Enugu now? Like in Enugu, we have about 5.
You have about 5?
Yeah, that's fine.
The statistics are alarming. It's frightening. So how do you cope?
We have about 5. We cope.
How?
We cope. That's why I'm saying in 1 to 33 million. So and Enugu serves all the local governments in Enugu. Then you also have the ones in Imo State. In Imo State, there are about 2 or 3. In Anambra, there are about 2. Then in Ebonyi, some of us now double cover Ebonyi and Enugu. So somebody like me, I do Ebonyi and Enugu. So then you have in Cross River, other places, just scattered here and there, and all of them are located are situated in teaching hospitals.
Before we got into the studio, we were having a banter, we were having a chat, and would somebody actually envy you, your work schedule? You're in Enugu, you're in a boy, you know the computer we just had.
Yes.
And it is frightening how you manage your life. I have a doctor friend who said he decided to be a public health physician.
Their own is not even any easier, because they are in charge of epidemiological studies and all that. So when time comes, they'll have their own problems.
Yeah, because there was this friend of ours, Dr. Bassi, that during COVID he handled over 400 patients.
So
and Couldn't even go to his house
That's
for that period because he was constantly interacting with these guys. Okay, well, you give an idea that this thing can be treated. Can it be
Yes.
cured permanently?
Yes, some of them can be cured permanently, some of them can be managed throughout life. I'll tell you, most congenital heart defects, some like simple hole in the heart, like things like ventricular septal defect, atrial septal defect, patent ductus arteriosus, even tetralogy of Fallot, some can be cured once you do the surgery, corrective surgery, and when they come on time, you cure them and they live their normal life. Live their normal life.
I know a family that had to go to Turkey.
Yes, that is why I would say, are we doing
I know a
enough?
family that had to go to Turkey.
That's why I say, are we doing enough? These things, they are amenable, but they are capital intensive.
How do families face? How many families can afford the treatment?
Any disease.
How expensive is it? It didn't even
Now,
first.
let me just tell you something. My teacher will tell you that he's a health economist. You see, once you spend more than 10% of your income in any disease, it's catastrophic. It drives you into poverty. In congenital heart disease or heart disease of any kind, we have both direct costs, indirect costs, and opportunity costs. So, you see, the direct costs is the cost you pay for the treatment, and the surgery is not, as at the last count, the surgery, the diagnosis alone, for you to make that diagnosis, you have to go through some basic tests like chest X-ray, echocardiography, ECG. So if it's becoming difficult, you can do what you call cardiac CT or MRI. We can have idea of these tests, and these tests alone, there are hundreds of thousands. Then after that, they now book you for surgery. The surgery ranges in millions, and our minimum wage is 70,000. And I know how many families can get up to 500,000 income a month. Then for you to do a simple PDA, that's simple PDA, like open PDA, is about, the last count when we checked is about 1 million or thereabout. But catheter own is about 2.5 million. For other open heart surgery without subsidy any place in Lagos, Ife, and other places is about 6 to 10 million. However, once in a while, we tend to have people that come to support us. These people come in from diaspora, they bring all the consumables, they do the surgery, the doctors come free of charge without any money to these patients. But it's not sustainable. It is not sustainable because they come once in a while, but every day you see children with this problem. So these people coming once in a while, there are lots of foundation, Save a Heart, Foundation, VOOM, and all that. They all come. They've established centers, they do these surgeries free of charge. No dime. They've done, even Obi Jackson sponsors some people, philanthropy sponsors some people, because they are not cheap. The lists in as at the last count that I checked is about 6 million. And they build this in dollars actually. They actually build it in dollars. So as the exchange rate is going, that is the cost. So they don't keep it in there because of instability of our currency. So they build the surgery in dollars. So they now convert it to what you are going to do. But the treatment is catastrophic for most families, and they drive them into poverty without help. So the only way that we advise is what we call universal health insurance. When they have health insurance, the government takes care of it. Government provides the facilities, the training, while people are willing, can come and help us. We need to start first. We are not doing anything to start. We are building hospitals. We need to start because people are going to come to these hospitals. People are going to have these conditions, but where are they going to get the money to foot the bill?
Okay, we talked about antenatal visits as very, very important. And then, is there a certain kind of vaccination during that, that could actually help?
Yes. One of the commonest one that we started is now rubella vaccination. When they do rubella vaccination, it helps to prevent it. helps. Another common thing that affects our children is, and even adults, because they tend to have it to the adulthood, is rheumatic heart disease. They are trying to develop the vaccine, but the vaccine is not yet available. So, well, this is something we'll work on.
Okay, nutrition. I know for whatever sickness there is, there's a certain level of nutrition that could help at the beginning. So, what should parents know about nutrition? What lifestyle habits promote heart health from childhood?
Yes. When I said something before about lifestyle diseases, some of the high lifestyle diseases, the heart diseases are lifestyle diseases. We're having it now. Over time, in 1992, we don't get to hear this obesity. Now, we don't have to hear some of these pediatric hypertension that much, but now it's coming more, especially in our adolescents. So, heart diseases in adolescents are lifestyle diseases like adults. Hypertension starts, some of them starts in infancy, then track to adulthood. So, like lifestyle diseases, we need to avoid obesity, exercise. Our adolescents now smoke. They take a lot of caffeine. Most of them now are keyboard warriors. They do a lot of internet facilities. There are no manual work, no exercise. You see them, they stay in one place, do video game. The screen time is increased. Air pollution is worsening. So, and they eat the fast food, eating fast food, these no fiber diets, then cheap condensed fatty meals. This time will produce them to obesity, and they'll develop hypertension. They'll develop cardiometabolic syndromes. So, and we are seeing them now in adolescent age group, which is very, very important for us to prevent. You mentioned adolescent young boys, 13, 15 years, you are getting a blood pressure of 140/90. It's already stage 2. So we need to watch what our children eat. We need to watch what we do in our schools. You see, you guys that are in education sectors, you see a child, you see a school, the next door is a fast food joint. Their signboard is a fast food or something nutritional. What else they use it to? So the child is always being reminded of the food and everything, and they do all sorts of adverts within the peak hours. In abroad now, McDonald's advert, all those is done after 10 o'clock, when children must have slept. So the lifestyle is very important. Our nutrition is very important. High fiber diet, things that grow on the ground and from the tree. We should cut down on processed food, sugar, cholesterol, high density cholesterol, and all that. So at least that will help us in curbing hypertension, especially in adolescents.
Okay, government. At the federal level, at the state level, at the local government level. What must government prioritize in this area? What must they do urgently? Because the figures you gave are quite scary, quite frightening. So what must government do at all levels to at least help those of you who are in this field?
Yeah, the challenge is, you see, governments should come in, definitely. They should strengthen the policy.
What tangible forms would they do that?
They should strengthen the policy of non-communicable diseases. We face more of the communicable diseases, HIV, malaria, tuberculosis. So while heart diseases and other are relegated on the background, but they contribute a significant mortality. Most of their sponsorship, most of their grants go to those infectious diseases. Little or nothing comes for these non-communicable diseases, because these are the ones they'll say more people survive. But this also causes significant mortality. So they should strengthen the non-communicable diseases policy, funding in non-communicable diseases. Then they should provide the facilities and training, and also improve the workforce welfare. So to retain the people already trained, they should provide the facilities, grants the doctors or the nurses, because the heart team, I call them the heart team. You have the doctors, you have the nurses, perfusionists, nutritionists, technologists. Is a team. The heart team is a team, comprises so many individuals. It's not just the doctor, the cardiac surgeon, the cardiologist, the anesthetics, the nurses, the critical care intensivists. Is a heart team. Even the electrician, even the cleaner. So for you to is a total team. In UNTH we have the cardiac team. So is a team. So the government should actually prioritize some of this and maintain the team, provide the facilities. They are not too expensive to do. Guatemala and other small countries have done it, and they are running their cardiac team. So that is one. They provide those funding, then provide facilities for training. You train people, because
You train and retain.
you train and retrain. You train and retrain people. Then offer them now. You can now say, okay, fine. I remember over the years, the National Health Insurance Scheme used to donate, sponsor any child with heart disease that is going for surgery. They offer 1 million to support that thing. It's a National Health Insurance Scheme plan. We can access it. There are also others to save 1 million lives. The money are being they are not even getting the money. So they can say, okay, this money in save 1 million lives can go to heart disease. If you have a good case and they can do surgery, then you can write for this. Do what you call strengthen our insurance scheme. Then approach to people. Use those earmark taxes that you collect from companies, maybe companies, and they let it be part of their social responsibility. Say, this year I'm going to sponsor so and so people for surgery. That's what Obi Jackson does that in Lagos.
Okay, mentioned, what is Guatemala you just mentioned?
Yes.
Okay. Is there any African country that has attained what you might see an enviable position in the treatment of children heart diseases?
Yes, I just came back from a training from the Gambia. Senegal does heart surgery. Gambia does. Ghana does. Sudan does.
Are they shade ahead of Nigeria?
Sudan does. I'm not talking about West Africa. I'm not talking about South Africa. Then Kenya.
Where is Nigeria in this graph?
Nigeria does heart surgery. Nigeria does heart surgery, but the government facilities that do the heart surgeries are quite few. They used to do in UNTH, but due to logistic problems, they're not doing. Then Ife, Lasut, Abuja, some centers, but there are some private places that do. There's one in Nnewi, yes. Also, I think it's also that Nnewi exists, or Ifite. There's one in Owerri. There are small pockets of places that do, but the important thing is for us to have what you call regional cardiac centers. If we pull all these resources, maybe Southeast will have a regional cardiac center, Southwest have a regional cardiac center. Pull the resources together. Than having all these pockets of place, then they are not sustainable. Because important thing is this: if you have the population, then a surgeon comes, he does one in 2 days or one in 3 days. There's what we call retaining scale. So, but when you have many, it helps you retain your scale. So pull the resources, so that this region has a cardiac center, this region has a cardiac center, so that all the resources will be pulled together, both manpower and human material resources will be put in different regions, so that even the patients will pull up that region, and people will be having this daily heart surgery. They do heart surgeries in Abuja, but all of them are all small areas that do some things in their enclave.
Professor Ujunwa, I want to ask you a direct question. That direct question is: assuming without considering a child in Enugu now has an emergency of a heart disease, where in Enugu can that child have a procedure? Is there? Because you want it. So, what about the emergency now?
A cardiac surgery that requires open heart surgery?
Yes.
None.
In Enugu as we speak.
As I'm telling you, none.
So where must the child? Where the closest place the child can go?
The closest place the child can do daily heart surgery is either Ife, Abuja, or Lasut.
So where Southeast?
They do in Orifite, but these one are missions.
Yes. It doesn't exist.
It doesn't that. Then they do in regions, where. That's what I'm trying to tell you. So important thing is for us to UNCH is National Cardiac Center for Excellence. That we need to do something. We need to pull the resources. The government can just say, okay, fine, let's sponsor Southeast, develop this place, make it standardized, provide all the equipment. We've been doing cardiac surgery in UNCH. We do it a lot, and I've participated in some of them. But what we need is support, consistency. The CMB is trying so much. People are there will have the manpower to do this. So if you have a child that need open heart surgery today in Southeast, we cannot get it. Is that bad?
This is dangerous.
Sad.
So it means that a lot must be done and should be done. And so I ask you, what must government of the Southeast, the Southeast Development Commission,
they can build us a cardiac center, sponsor it, name it a cardiac center, get any institution of their choice, build it, develop it. They can even invite the surgeons, they retain them, then they transfer the skills. If that is what we say, because we are saying this because we are not affected. When you see a family that is affected, then you understand. Losing a child is terrible for any family. It's emotionally draining where you can.
Okay, in the course of your professional duty, can you remember one particular procedure that was a success, or was a failure, or that challenged your professional competence in this area?
Well, we've met a lot of challenges. We've also recorded some successes. The simple ones, we've been taking care of the simple ones. Some of our cardiac surgeons are doing very well. We've done some challenges. There's one when may his soul rest in peace. One Professor Nisuba.
Okay.
Yes, may his soul rest in peace.
Yes.
Teacher. So we made this diagnosis together. This young boy, he was about 17. We did the echo. They have been going around, going for prayers, and we just made it and saw that this child has aortic valvular disease due to rheumatic heart disease. We pushed the child to UNCH. Right, followed the child to UNCH. We did the surgery. It's now 6 years going now, and we repaired the aortic valve. The local team repaired the aortic valve, and the child is alive today. I still see the child. I still see the boy now. He's a boy. He's a man now. And there are other ones we also treated maybe during the cardiac missions. We closed their defects. Some of them have VSD. Some of them, they're all in the university now today. But there are ones we lost that we could have done something. And we've had some cases that some of them, they will come with complex cardiac disease. Then you tell them, but most times you tend to tell them that we are going to see what we can do to salvage them. Maybe,
but it's a lost case.
Well, as a doctor, I don't know anything that's a lost case. So we try to do that, and cardiac surgeries are not without complications. And the child came out very well, but 6 hours later, the child started bleeding. And that's what's it's not only a rosy affair, but you need to counsel them, tell them what they are going to go through. Sometimes a 6 hours procedure, 8 hours procedure, depending on what you are doing. So Some of them, the PDAs, they are simple. They don't need open heart surgery. Some of them are alive today. They are in university. So as we started doing this thing since, it's interestingly UNCH was the first place they did open heart surgery in southeast, southwest.
So what went wrong?
Well, I'm not the
That's how you work. Okay, what was the last heart surgery of a child done in UNTH?
I can't remember the last. I think it's about before the COVID.
Okay, that's before 2020.
Before the COVID. Yeah, before the COVID.
Okay, let's look at some myths and facts about that they said heart disease affect only adults.
It's a lie. It's not true. It affects children and track to adulthood too.
Okay,
Because if you're not taking care of it in the childhood, it will come in, it will still be with you. So especially if you're hypertensive, you're not controlling it. If you have congenital heart disease, maybe a hole in the heart and nothing is done, some of them live till adulthood, and when they come to adulthood, they'll still see the hole in the heart. It doesn't disappear, in as much as some can close spontaneously, but it's still there.
okay. Child who has a heart disease cannot live normal life.
A child who has heart disease, if he's taken care of, can live normal life, live well into his adulthood and give birth to children. But if he's not, they tend to die maximum within first decade of life.
In my village, I'm not going in a village. They say heart defects are always caused by spiritual attacks.
Well, it's interesting. They are not caused by spiritual attack. They can be acquired or congenital.
And most parents have had this that nothing can be done once a child is diagnosed.
No, things can be done. Actually, things we are still doing something. Because most of them, we pediatricians, we are the gatekeepers. We see these children firsthand. They come to us with heart failure. We treat their heart failure, manage them, tidy them over. We can even keep them for some time till they have the money to do the surgery, and give them drugs, manage them, do their investigations, make sure they don't get infections. Because one of the things that kill them fast is what we call infective endocarditis. Another thing that kill them is bronchopneumonias, then heart failure. So we tidy up those children, make them stable. So sometimes they are lucky enough. All those missions will come. They get surgery and they are well.
Okay, they said once a child, you look at a child, and the child looks very healthy, then checkups are necessary.
No. That's the point. And I must tell them, now let's use this video. You see, some mothers come to me and tell me, my child is healthy, give me a medical report. I say, no, go and do check. You do check. Some of them are incidental finding. You can just put a hole. I remember one child, that's a very interesting story. When children play with their stethoscope, one child came, and incidentally, the mother of that child is a doctor. The children they were playing, they were just touching themselves with the stethoscopes, touching their heart. You know how children do. So one day, the child now listened and say, mommy, Kamsi's heart is not beating like other people's heart.
Okay. He touched the other, and touched Kamsi.
And touched Kamsi.
Yes.
And he went to report to the mother that Kamsi's heart is not beating like other children's heart. The mother being a doctor, this just struck the mother, and lo and behold, there's an abnormal heart sound. And the mother listened and shouted and brought the child to our clinic. Today, the child has had heart surgery because there is a doctor. He had heart surgery. The child is well.
That's dental discovery.
That is what I'm trying to tell you. I just gave you an example that some of them can be incidental find. You come for another thing checkup. They'll just put. You are going around without knowing that you're a time bomb. Most of us don't even check our BP. In children, once a child is 3 years, you must check the blood pressure.
Okay, question is, which may be our last question, is if you had a minute, 2 or 3, to speak directly to parents who are watching you on this program, what will you tell them?
First of all, the parents are super. I encourage them. But I'll tell them to be more mindful of their children. Go to regular, once the child is sick. You see, there's no common thing that we all say is not my portion. It's not my portion. I call it is not my portion syndrome. Once a child is ill, or even the child is going to school, Take the child to a doctor. We patronize all sorts of quacks in this environment, and our sorry for the pastors and prayer warriors and all those quacks. Please, yeah, prayers are good, but Luke in the Bible was a physician, so that they should actually go to a proper physician who will examine their child and now appropriately diagnose and tell them what is wrong with their child. There are all these myths. Doc has actually said they don't exist. Things like this, they don't exist. Please take the child for a proper checkup. It might look expensive, but it's much cheaper when diagnosed early. There is still hope. That's why we are doing this. We can still help these children. Both the government, ourselves, the doctors, the media houses, the school, everybody is a stakeholder. Awareness is the key. When they are aware that things like this exist, they'll look for solutions. But if you are not aware, ignorance
It's not an excuse.
is not an excuse. So we need to be aware. There's what we call PID, poverty, ignorance, and disease. So it's a vicious cycle. So we need to break that chain.
And finally, to our government, and we just talk to them. What must they do? What must they not do? And how urgent can they do those? In the southeast,
In the southeast, Nigeria in general, we should strive to strengthen our health policy, provide funding for non-communicable disease, because heart affects every other place. Provide funding for non-communicable, support training, then work towards establishing a Southeast Regional Cardiac Center.
well, I think this is a good place to leave this conversation, Professor Ujunwa. For viewers, heart disease in children are real. You've heard that, but many can be detected early, managed effectively, and in some cases prevented. So today's conversation or discussion reminds us that protecting our children's hearts requires a collective effort from parents, healthcare workers, schools, policymakers, and of course the media. So our sincere appreciation to our guest who has actually enlightened us today. I'm a bit enriched by the conversation we had this morning. And so we say to Professor Ujunwa, consultant pediatrician and professor of pediatrics at UNTH, thank you so very much for sharing your expertise and insights. We really, I'm sure everybody in the studio, if you're watching the demeanor, you see they were actually like, wow, is this, because most of them are fathers and they have sisters and brothers. So thank you very much, everyone who joined us on Beyond the Headlines. My name is still Ujunwa Cyril and I'm your host. So until next time, which is of course is tomorrow, stay informed, stay healthy, and remember, every child deserves a healthy start in life. Have a lovely day ahead of you.